So good morning, everybody, and welcome to AIOS. And this time, I think it's a mega event because we're doing it after so long. And this early in the day, I'm so happy to see you all here. We'll be doing this IC on DME management. We've been doing this course for the last couple of years, and it's been pretty popular because we're covering all aspects of DME management, right from the imaging and when is the ideal time to switch. When do you call for a combination treatment in DME? And we have excellent faculty to cover all these topics. We'll also be doing a very important topic about DME worsening after cataract surgery. I think that happens and how to handle these patients, and whether surgical option is the best or whether we wait with treatment, and how to handle recurrent or persistent DME. So for our first talk, I invite Dr. Santosh Gopi Krishna. He's my colleague and friend at Narayana Nethralaya. He'll be talking to us on advances or the uses of Octa in DME management. I request the faculty, if they'd like to join us on stage, please do. Uni, if you're going to be here for the full course, or Rajiv, please.
Morning all. First of all, I would like to thank Dr. Chaitra and AIOS for this opportunity. So I'll be talking about Octa in DME. So these are the layers of the Octa, as we know, the coming from the superficial, deep, and outer retina and CC layer, which we are all now quite familiar with. But when it comes to DME, since it involves the blood vessels and the capillaries, we are more concerned about these layers, the superficial capillary plexus and the deep capillary plexus. The instrument what I used for this presentation is the OptoView. We do have many companies that have Octa now, but OptoView is the one what I had used. So it is said that there are many studies that have shown that FAZ is altered in diabetic retinopathy even before any macular changes they set in. So FAZ kind of increases in size, the vascular density kind of decreases. So that's what happens. So this is the angioanalytics. That's a machine-built software that is there, which gives us the post-image acquisition processing. The many indices, like wherein you can see vessel density, FAZ area, asaccularity index, and the many more that have been coming up, and many studies that I've done. And even we have an in-house fractal dimension wherein we have seen spacing between large and small vessels also. So there are studies. This is how they do is they do kind of binarize the image, then they skeletonize, and then kind of they see the spaces, they see the FAZ, and they see the vessel density. So when you look at a normal OCT and a OCT with macular edema, these are the dark, the red areas are the ones wherein there is capillary, maybe like non-perfusion, not exactly because of the edema there, we can't call it non-perfusion, but these are the areas where there is loss of blood supply or decrease in blood vessels over there, rate fraction. So we did a study in cases with diabetic retinopathy without macular edema. We had seen progressive decrease in vessel density and increase in FAZ over grades of diabetic retinopathy, but it was not statistically significant in both layers across grades, but FAZ also did not significantly change, but the spacing between the vessels changed when the diabetic retinopathy grade increased. So this is a typical case of diabetic retinopathy with macular edema. You can see the altered FAZ, which is more prominent in the DCP, most probably because the section goes through the IPL and the OPL. So that is where you see these dark areas and really can't make out the vascular changes that happen here. So it's kind of an artifact. We need to be careful when we interpret this. So this, when you compare it with an FA, this is an SCP and this is the DCP. These are all 3x3 scans which I have used because of the high resolution. You can see this vascular dilatation and tortuosity. You can see the FAZ break and the macular ischemia here, which is these changes when comparable to FA, the most seen in SCP, but DCP are the main area where things really happen. So another case, you can see macular edema, aneurysmal dilatations. You can see these aneurysms and altered FAZ here, and most probably again we need to check where the scan is really passing through when we really kind of come to a conclusion or say that this is a drop in vascular supply. So the chronic DME, these are the unfast images what you get along with the Octa image. So this also gives a rough estimate of the extent of diabetic macular edema and the prognosis as such. So this is a case of non-responding DME. The 6 mm scan. The problem with 6 mm scans is the resolution really comes down. So it's really difficult to make out, but you can roughly make out what's really happening. There's too much of vascular distortion here, non-perfusion areas, aneurysms. So this is a corresponding unfast. So we did an in-house study wherein we compared these aneurysms across two machines. So maybe because this was between OptoView and Spectralis. So Spectralis obviously has more B scans. So somehow we found more aneurysms that were there in Spectralis when compared to OptoView. So this is what we have in-house. Our in-house team had developed this, the local fractal dimension. So we can see the spacing between large and small vessels, FAZ, and the vascular density also. So these were the changes. So Spectralis somehow was more able to detect these aneurysms when compared to OptoView. There are many articles which even showed the aneurysmal changes that happen, what really goes on. In a good response DME, you can see a good response DME here and a poor response DME here. The aneurysms are obviously more in poor response DME in a DCP layer when compared to SCP in a poor response DME. So then again, this is a case of responsive DME. This is a recurring DME in the right eye and poorly responsive DME, but again recurring in the left eye. So you can see quite a lot of changes like drill and outer photoreceptor damage and other things. So, but when you look at the FAZ and the drop in areas, it's more significant. Even the aneurysms are more significant in the poorly responsive DME when compared to a good responsive DME. But this is a recurring case, so that's the reason you can see the chronic changes that's happening there. So many studies again showed what really happens, what are the risk factors for poor visual acuity in a case of diabetic macular edema and OCTA. So they found that increased irregularity in FAZ and extensive damage in the DCP and larger FAZ area, and when there's initial high foveal thickness, these are the risk factors for poor visual acuity. And then again, there are studies again which showed that in a poor response DME, you can see the disrupted OPL. This is because of the disruption here, or autonuclear layers kind of breakdown. So when there's a communication, you can see the drop in vascularity over here. So coming to the importance of DCP, now we know that DCP is more important in DME when compared to SCP. So the synapse between bipolar cells and photoreceptor cells here happens in the wall. It's because it's a voluminous layer. And since OPL acts as a fluid barrier, intraretinal cysts between inner and outer nuclear, they communicate to the disrupted OPL, and this leads to the eventual damage and non-responsiveness. So DCP again supplies about 15% of oxygen to photoreceptors and inner and outer nuclear layers. So this layer is extremely important for vision as well as response to DME. Then again, there are again studies which showed that where do the aneurysms really lie? Do they lie within the edema area or do they lie outside the edema area? So it's known that these aneurysms are more seen within the edema area when compared to the outside the edema area, and these are more significant in a non-responsive DME. So this is how it is. Again, DCP has more microaneurysms, and when retinal thickness is more than 400 microns, all these aneurysms are more concentrated in DCP, almost around 91%. So many studies that have shown that where they usually lie aneurysms and all. So the ultimate conclusion is it's morely in the DCP. This is again before and after reduction. You can see the aneurysmal changes. And we should be mindful of the artifacts that can happen. These are because of the saccades, microsaccades, because of the microsaccades in the z-axis. So these are called suspended scattering particles in motion. So these give rise to areas wherein it looks like there's a flow there, but there's no flow there. So we need to be mindful when interpreting an OCTA. So there are again studies which showed that the hyperreflectivity and hyporeflectivity, whether that corresponds to non-perfusion. So you need to Zeiss and AngioView, the difference between the two machines again. So AngioView has a little less hyperreflective spaces here, whereas Zeiss has more hyperreflective. So when there is hyperreflectivity with no SS PAM, then you should consider these as NPA, non-perfusion areas. When there is hyperreflectivity with SSPM, then these should be considered as perfused areas. Then again, when you look at these things, it doesn't mean that there's a non-perfusion and loss of the vessel. Once the edema comes down, the vessels kind of resurface. And these are called the remodeling of the vessels. So this also has to be kept in mind. So then aneurysms, even if you follow over a period of time after 1 year also, Sometimes aneurysms which have low flow, which are not detected on Octa, they can remain like that. Maybe the edema never recurs, but in case of recurring edema, you can see that the aneurysms are active and the flow is there. So that is caught by Octa there. To coming to the salient features, Octa has shown that DME when better aphasia and visibility kind of gets better once the macular edema comes down. So the remodeling of the vessels, vessel displacement, all should be kept in mind. The enlarged aphasia in deep capillary plexus, these are basically because of changes in the diabetic macular edema. The many difficulties when you are interpreting Octa, the differentiation and segmentation is extremely difficult in anatomically distorted scans. So you need to really sit at the machine and kind of see what's really happening. You can't really read a printout and say that okay, there's a non-perfusion. Projection artifacts again have to be kept in mind. The many misleading features like SSPAM, wherein edema and hard exudates can give rise to a suspicion that there's a flow there. So to conclude, it's a three-dimensional non-invasive evaluation of the structure of the edema. Understanding, I believe it's in a routine practice, I just used to go back and see what's really happening there if there's a non-responding edema, or to rule out macular ischemia. You can even do targeted treatment based on aneurysms. For academic interest, you can see these aneurysms, so what really happens in the CNP areas. Thank you so much for your patient listening.
Thank you, Santosh, for that overview of Octa. So from what I understand now, it's basically a tool to prognosticate.
That's
right. For patients, despite no edema, still having poor vision and probably not wanting to do an angiography every time. So I understand that as of now, Octa will still remain a prognosticating tool, or are you looking at a future where we'll use Octa over OCT for diagnostic or follow-up as well?
I think the problem is the artifacts and difficult to kind of interpret directly. I mean, because you are concerned about the flow areas, non-perfusion areas, which is not very easy when you are reading an Octa. Though you have post-image processing protocols, we do have in-house protocols wherein you can remove these artifacts, but it's again not easy. You can't really go by the face value of it. But if you look back, there are studies which show that a good response to even bevacizumab. They say that the initial presence of good number of vessels, there's a good response, something like that. So you can go back and check, or you can progressively even monitor these scans.
I think one question which I always have in mind, will it totally replace fluorescein angiography for DME? That is the question. Fundus fluorescein angiography, because that's being invasive. I think if that because anyway OCT is done as part and parcel of most of the Octas. So that is the big question.
Right.
So what do you feel about that?
I think chronic macular edemas, I mean non-responding, we do kind of go ahead and do an FA there, sir, most of the times. But the aneurysms that are detected by Octa is not equal to what is detected in an FA. So because of what you call infarction and occlusion. So it's not very easy.
I wanted to ask, is it important now for us to detect every aneurysm, since we are not, treatment methods are different, we are not really targeting. So that's what comes to my mind.
Can I take that, please? So I'd like to say that the concept of the question of Octa replacing FFA is a moot point there. Every day we are learning new things about Octa and looking at DM in a totally different way, not just seeing the size of the FAZ. The FAZ itself, there's a big controversy as to whether you have to look at the FAZ as a whole slab, whether you look only at the SVP FAZ, the DVP FAZ. So what does this mean? That it means that every day we are finding new ways to look at a particular problem. The current issue is that we have not enough data to substantiate what is important and what is not important. But that only time will give us. When we started with the OCT, we just measured the central retinal thickness and that was it. Now we look at the type of edema, we look at particles suspended, we look at all these things. So give it another 5 years and OCTA is going to be a different investigative modality in DME. It is the question of replacement of FFA is not there. And another point to that is that we cannot separate OCTA from OCT. You cannot interpret an OCTA image unless you have the OCT right by its side. There are protocols like the Humphrey field analysis, which now the reporting system is going to be like you have to have the corresponding OCT, the corresponding on-fast image, and the corresponding OCT image to really interpret what is happening in an Octa image.
Well, I invite Uni to start off his presentation. One last question, Santosh. Like how we have quantification methods for OCT, do you have anything where we can, map out which are part of the algorithms to quantify? We continue to monitor the ischemic area, right? Through the algorithms itself. How do you quantify the ischemic area is what I'm saying?
Yeah, you can, but again, you need to kind of change the segmentation and then see.
Manually.
Yeah, that's other problem. You can't really go by.
The
Most of the studies they have taken the default segmentation, but if you kind of change, everything changes. Okay. So if you look at the limitations in all these papers, they say that. So the limitations again is the fluid that is there. If it's a flat macula, nothing like it. But if it's not a flat macula, it's not easy.
True. Thank you so much.
Thank you.
Over to you, Ni.
So, good morning, everybody. Thank you, Dr. Chaitra, for the invitation. So, I'm just going to a very, not a routine topic, an interesting topic, but slightly slower than the Octa. So, this topic you can also consider as this. What are the treatment options for anti-Vegf resistant DMEs? So, it's the same thing. When do you switch? So, this is something that is written in one of the studies that 20% of diabetic retinopathies do not respond fully to anti-Vegf treatment. But I would go to say that in our practices, we're looking at nearly 60 to 70% probably. And we'll just go to the reasons that why we say that they don't respond properly. It's not one answered questions. I have 10 unanswered questions over here, starting from what do you really call a poor response? What do you mean by a suboptimal response? Are there differences in the CME or DME that don't allow them to think? Is there a real difference between the anti-VEGF agents? What do you really mean by treat and extend in DME? So we'll go through all these. What are the characteristics and the biomarkers for switching? We'll just go through some of these questions. Okay, so before we define anything, we know we have to, for the sake of this discussion, what was considered to be standard treatment? Standard treatment was considered as 4 injections, then a 5th injection and a 6th injection over a period of 6 weeks, and laser at 24 weeks if it didn't work. Okay, this was the studies. Okay, we have to keep this aside, but we just have to know what was meant by standard. And this was how treatment was managed. That when you give anti-VEGF after the loading dose, if it improves, you keep on giving. If it doesn't improve or it's the same, you do not. If it worsens, you keep on giving. So that means if it is improving, you keep on giving. If it's worsening, you keep on giving. But if it is static, you have an option of, this is what the study protocols defined. And what was meant by success? Okay, we have success in treating DME was called anything less than 6/6 vision as a vision criteria and less than 250 microns. If you're using a Heidelberg, this 250 is 320 microns because the estimation of DME is, the values are different. An improvement is when it improved by at least 10%. No improvement was called it didn't increase by 10%. There are 2 terms called futility and failure also. Futility is checked after 52 weeks. So essentially, these are the definitions by the DRCI network. But we are more focally concentrating on 2 definitions. What do you mean by persistent DME? Persistent DME was tagged with a figure of 6 months. And then you had the OCT criteria of 250 microns. Then you had chronic persistent DME, which was 6 months plus 2 visits. That is, you take it up to 8 to 9 months. So these are the definitions that are around when you're dealing with DME. So that was the point of defining what do you mean by standard treatment. Now let's define poor response, okay? So essentially, if you look at the figures, roughly 70% of people have either a poor visual response or a poor OCT response. That's a really important fact to know, that a patient coming to you with DME, 7 out of 10 chances he'll still have DME after you try your best with him. So when do you consider anti-VEGF response? Again, the 2 values are less than a 25% decrease from the original. We're not talking about 10% here. And we're considering about if the value does not come between 225 to 300 microns, you consider it as anti-VEGF resistance. But the funny thing is that for the point of switching, there is no definition of, none of the studies have mentioned a definition per se. What do you call it as DME for the point of switching? So we are just dealing with monotherapy definitions here. Why do you call it chronic? When do you call it chronic resistant? When do you call it persistent? This is something to keep in mind throughout the whole presentation. Second question, is it really a suboptimal response? So before you label a person as being anti-VEGF resistant or not responding, the most important thing is to check two things. Has the fluid gone away and has it come back? Then it is not persistence. The second point, is the visual acuity maintaining or is it improving? That's also important. And the third point is that, we'll come to the third point later. I'm just keeping it as a little bit of stuff. But these 2 points, you have to really know whether you're going to call it a persistent DME. So, and this is the point I'd like to make. Underdosing with anti-VEGF is the most common reason for calling it a suboptimal response. We convince ourselves that you're treating the patient properly. The patient says, okay, next injection 4 weeks, or my domestic help was not there at that time, so I came 2 weeks later. You're underdosing him by no fault of yours and no fault of his or hers, but still you're underdosing him. The injection is 2 weeks late. So let's look at some other things that are not under your control. The persistence of edema could be independent of VEGF. Okay, there are lots more other VEGF factors which you're not suppressing. Let us not presume that all DME is because of VEGF. There's platelet-derived growth factors, there's placental growth factors, there's a whole gamut of markers over there which we're not looking at. And the fun point is that the more VEGF you get, the more of the other factors are going to be enhanced by blockade. So this is also a reason why DME does not respond to VEGF sometimes. Now, the whole fun about switching, I would say, is in your mind more than the patient's mind. When you say, this is not working, I'm going to switch you, you're excited about it. Every compliance patient issue the patient had with VEGF, anti-VEGF A, is still there with anti-VEGF B. So unless you note and treat or take care of that particular thing, why he hasn't got an injection at 4 weeks? Why is he getting at 8 weeks? You switch from A to B, the compliance, the patient is the same, the compliance issues are the same, the patient's domestic help is the same, the lack of the driver is the same, all those things don't change. So you have to address compliance issues before you change the anti-VEGF. In a real life scenario, let's look at suboptimal treatment and suboptimal response. When you don't, in a real life scenario, if you don't get any response after 2 injections, that's a time to pretty much think that you have to think that something may not be right. You could even look at, I would say 3 rather than 2, sorry there. And you're looking at a 20% reduction. So I put this in 3s, 3 reasons for treatment failure, okay? And what do you mean by customization? For me, there are 3 types of customization. One, you give the patient a treatment holiday. Why it is important, we'll tell you. Second is a switch. That is the main point of this topic. And the third is adding other modalities. So there are 3 mechanisms of VEGF. That is permeability, inflammatory, and leukostasis. I'm not going to that. But essentially, the 2 mechanisms say that one is VEGF mediated, one is VEGF plus inflammatory mediated. And that is why VEGF does not work all the time. Suboptimal response. As you said, there are inflammatory pathways along with VEGF pathways, okay? And what happens when you give more VEGF? There's a blockade and the VEGF resistance increases. Suboptimal pathway number 2. This I have no control over this. There is something called VEGF polymorphism, that the VEGF inside your body need not be genetically the same for X, Y, and Z individual, which means that one standard anti-VEGF may not block your VEGF levels in your person because it's not the exact genotype or phenotype of VEGF traveling in you. And the most important thing for a suboptimal response is what I said, poor compliance to the schedule. There are new 3 paradigms that I'd like to talk about. One is classifying DME into early and chronic. 2 is looking at we'll just go through this. So what do you mean by early and chronic? See, there's nothing called acute DME and chronic DME. The new thing is rather you call it chronic versus non-chronic DME. So by definition, then one is VEGF driven and one is not VEGF driven, which means that when you have a non-chronic DME, it responded to anti-VEGF and all your conventional things. But the chronic DME, that is one that doesn't respond to VEGF, responded to low dose steroids in the long run. That is, in terms you're talking about dexamethasone. The next is looking at the response. There are 4 types of responses: early, consistent, early, inconsistent, slow. Barring the first one, all the other 3, after 3 injections, you may feel that the patient has an anti-VEGF resistance. You may switch early, but you can imagine the second one. It responds first and then it doesn't respond. You're caught. You think it's not responding anymore. The third one, it responds slowly. By the time you give 3, nothing happens. You call it anti-VEGF resistance. And the last one, 25. All of this is 25% each. If you look at it, the last 3 consist of 75% of the DMEs you treat. They don't respond within the 3 months. And you feel that you have to change the drug or add something at that point of time. So let's go to the paradigm 3. This is what I'm saying. This is an interesting thing. The more anti-VEGF you give and the more resistance you happen, you see cystic spaces happening, you see outer retinal atrophy, and you create a type of edema that is structurally changed and doesn't respond to anti-VEGF anymore. So this is the third paradigm. That is, over-treatment or continuous treatment with anti-VEGF gives you a type of edema that doesn't respond anymore. Is there truly a difference between the three agents? Before that, we've got to learn these three things. What do you mean by tachyphylaxis, tolerance, and not true non-response? Tachyphylaxis is the drug response, and with each subsequent dose, it stops responding. Tolerance is not like that. You a long time a drug, then after some time, it just one is a humoral immunologically based, and the other is more pharmacokinetics. And true response is somehow it hasn't responded from day one. So one of the paradigms is that, and the study says that continue unchanged for 24 months. This is from the studies, and it said that you had modest gains after maybe 6 months. So this is what, you still had nearly 40% who did not respond in 3 months and 50% who were late responders which continued after 6 months. Change the anti-VEGF. Can I have just one more minute? What is the logic between changing the anti-VEGF? The logic is that all of them have different half-lives, all of them have different molecular structures, but the only true change, if you look at the substance, would be aflibercept, which also inhibits two other molecules as a placental growth factor and Vegf-B, which using common sense would have a better effect while switching. So all the studies, see, I'm just going to go through this very fast. There are 4 studies here. 2 of them said ranibizumab was better than bevacizumab. 1 of them said aflibercept was better than. So we know that there is a hierarchy over there, but all of them said that the vision didn't improve. Okay, that is the sad part of it. The edema came down, the vision didn't improve, which means that by the time you diagnose chronic CME and you keep on treating and changing, the visual potential has been limited to some degree. So an early swift action may be what we're looking at, and that is a recommendation nowadays that. I'm just going to skip these. That is a recommendation nowadays that you go for a low dose steroids at the ideal time rather than switching anti-VEGFs. What is the importance of these studies? They say that yes, it is better. It improved the OCT edema. It improved the vision better than the anti-VEGF monotherapy. But this is what is more important, the yellow line. More patients who were switched had larger jumps in vision. That is, prevented it from going into a chronic structural DME which did not respond to further anti-VEGF. That was one particular point of the steroids and how they work, the switch. A steroid switch, in the end result, the study said the vision was equivalent, this thing, that thing, but more patients had large jumps in vision, and that is what we see in our clinical practice also. Rapid, suppression of edema and large jumps in vision. So there are some biomarkers, I'm not going to, the presence of subretinal fluid and the presence of hyperreflective foci in many studies have been told to be better markers to say that this is a time to switch. There's one study doing a direct between bevacizumab and dexamethasone, the Bevodex study. Cataract interfered with a lot of it, but generally the results with the dexamethasone were better. So I'm just going to, what is a switch? It's a time to switch tactics basically. So is it good to continue with the same anti-VEGF? The studies don't allow that. They say it's not very great. Is it good to switch from different anti-VEGF? Yes, but the data is not conclusive enough to say that it is great. There are multiple varied studies, different protocols, different time periods, different interventions. Dexamethasone switch is supposed to be the best result, and you just look at this slide. It tells you that you have got 2 comparative huge studies. There's a meta-analysis, 31 studies. Look at the visual acuity gain at this point of time, 9.6 versus 4.7 letters, and the number of injections, that is based on this, but and the follow-up period is comparable. So you have evidence to say that the switch is best with dexamethasone. After that, you can continue with anti-VEGF once you get a result, but the whole key point there is to prevent the non-chronic DME converting to a chronic structural DME. These are some of the other specific uses of steroids in DME management. So there's only one question to answer. In your practice, what is sensible and what is not sensible? Flogging a dead horse with anti-VEGF where you have poor compliance. Compliance issues with Ozurdex is much better because you don't have to do anything for the next 3 months. Cost is definitely an issue, but it can be rationalized. To summarize, I am a keen advocate of 3 things. That is, the first 3 injections you just don't inject. You have to assess what you mean by the response of this patient. The second point is that if you have an anti-VEGF scenario, either you switch to a steroid or you give a 1-month drug holiday. Take the patient off the drug and see what happens. You cannot assess how the anti-VEGF works unless you assess what happens when you don't give an anti-VEGF also. So we have to relearn. It's not a one-fit-all. It's a tailorized, customized treatment for DME, and it makes a huge sense. It's not visual acuity OCT inject. No, it's visual acuity OCT. Look at the history of the last 3 months and then take a decision how you're going to do the next injection. Thank you. I'd like to invite you for our retinal imaging meeting also. It's in 22nd and 23rd July in Trivandrum. We have all these stalwarts there, and we're going to have a wonderful conference just on imaging. Thank you.
Thank you, Uni. While I request Dr. Rajiv to please connect his laptop. Sir, do you have any questions?
I have only one question, and that is probably a problem with our country. Why you said 60% versus maybe 30-35%. We have always undertreated DME in our country. We are satisfied with 3 injections. No, I think this 6 injection thing or 5 injection thing with Eylea and 6 with makes sense, which I realize now. Once we are using, many of these patients are responding. I even showed a patient yesterday injected with Ozurdex also. Once intensive treatment, 5 Eyleas were given, it came down. So I think we have not really treated the way DRCRNet and other studies told us to treat. We somehow put it same way as AMD, 3 injections and then PRN. That is why I think we have 60%.
Yeah, that's absolutely right. So see, this is a 2004-2005 concept when anti-VEGF miracle cure, 3 injections. That's stuck to everybody's mind. Whether you started using in 2004 or 2015 or 2020, this got stuck. 3 injections, anti-VEGF, you're cured. And that's your counseling that you give to the patient, unfortunately. It comes through your mouth sometimes.
Yes.
There's one thing I have noticed personally. Too many anti-VEGFs also cause you check the morphology on the OCT. Sometimes the central subfield thickness or central macular thickness goes below 225-200. That's a setting in a macular atrophy drill, the loss of inner segmentation of the retina. So that time I stop, and somehow I've seen Eylea and aflibercept are very notorious to cause this macular thinning, and this leads to irreversible visual loss. So I hold my hand when the central thickness goes below 22-25, but that's my opinion. If I feel there's some edema, minimal edema, I'll go on to aflibercept, I'll go on to eccentrics or Lucentis or even nothing. If there's a small tiny vesicle over there, or maybe sometimes it's a ORT, look at the morphology. Don't just go by vision or the thickness. I mean, don't go by just the vision. Or that grossly you see some cystic changes. The cystic changes may actually be ORT. ORTs are too many. And ORT is a sign of neuroretinal degeneration. So there's no point injecting an ORT eye. You're already causing neuroretinal degeneration, and anti-VEGF will further cause neuroretinal degeneration. So it should be a blanket anti-VEGF and anti-VEGF. No. You have to see the morphology, then take a decision whether you really want to inject or not, or let the patient be as he is. Maybe he'll retain better vision in the long run.
Thank you, sir, and thanks, Dr. Uni, for that in-depth analysis into why we should switch and when we should switch. And like you touched upon combination treatment already, Dr. Rajiv will tell us more about how combination treatment can help us in getting better success in treatment for DME. Thank you, Dr. Rajiv.
Thanks, Chaitra. It's a pleasure being in AIOS in this IC. Next couple of minutes, I'll be more sharing some evidence. What is the combination intravitreal therapy, steroid and anti-VEGF, how feasible and how successful these are. So Unni had shown this, that DRCRNet protocol I did tell us that early and consistent effects are seen nearly about 49%. And then you have all these 4 categories. Approximately about 40 to 50% of center involving DME have variable poor response to intravitreal anti-VEGF agents. And all the clinical studies have also tried looking at what are the predictors of response. There are many of them, And now we also know a lot of biomarkers on OCT, as Dr. Atul was rightly mentioning. There are a lot of other features which you look, the morphological features. And all of them, or many of them, they predict poor response to anti-VEGF. This was one of our study where we tried looking at vitreous cytokines. So we did the vitreous reflux, what comes out after giving anti-VEGF. We analyzed about 28 cytokines. And we looked into PDR, DME, and no diabetic retinopathy. And what we all know, for probably proliferative diabetic retinopathy, VEGF is very important. It was very high. And even in DME, it was high as compared to no diabetic retinopathy. But if you see PDR, it was nearly 2.5 times more as compared to no diabetic retinopathy. But if you look at other cytokines, they were very, very high. Many of them are inflammatory cytokines, especially in DME, and IL-1B, IL-1RA, IL-6, 7, 8, all of them were raised in diabetic macular edema. So intravitreal anti-VEGF are the first line, definitely in center involving DME, but there are many non-VEGF mediators in center involving DME we know, and there are again good evidence which suggest that there is a role of intravitreal steroids in center involving DME, which show a poor response to anti-VEGF. So this is definitely known. Lot of literature is there on that. Let's look into what happens when we inject steroid versus anti-VEGF, the vitreous pharmacokinetics. So you can see there is a big burst. So it's nearly 10 to the power 5 to 6 times you get dexamethasone molecules the moment you inject. And this burst continues for nearly about 60 days. That's what clinically we see, that probably about third month the response of steroid starts reducing. If you give anti-VEGF, again there is a big burst of anti-VEGF molecules. Now does it really make sense giving both together? No, because again one must realize that even steroids have got an anti-VEGF effect. So it will also block the VEGF, and now you are giving two molecules. It's something like they both compete to the same receptor. So do you really want to add both and give? So can we combine steroid and anti-VEGF, and is there any evidence for that? There are evidences. So people have tried looking at giving both together. They've also tried looking at, can we give it alternately? Give 1 month steroid, then change to anti-VEGF, then change to steroid. Let's see what the evidence tells. So both together, this was one of the earliest study which was done with bevacizumab and dex implant together. This was a 1-year study. And they found that definitely at the end of 1 year, both the groups where you gave combination versus alone bevacizumab, there was no difference as far as visual outcome is concerned. Yes, those who had steroids combination, they had better OCT outcomes. That's what this study talks. Then there was this DRCRNet protocol U. The problem was this was only a 6-month study. However, at 6 months, they also found that there is no difference, the same what they found in Avastin, the initial studies. Here also they found the same. There is no difference in vision, but had better OCT reductions as far as combination is concerned. And more recently, there is another study with Eylea. So they tried looking at, can we combine Eylea and dex implant? And they found at 6 months, again a short-term study, there was no difference as far as vision is concerned, and OCT reductions as compared to combination Eylea plus steroid versus Eylea, they are same. There is no difference as far as OCT outcome is concerned. And these were all prospective studies. One was a retrospective study, but we know the gold standard or the highest level of evidence are these meta-analysis. There has been one meta-analysis which tried looking at combination of steroid and anti-VEGF and DME and outcome at 1 year. So these are called as forest plots, and if you have this diamond, the black color diamond, so if it is towards the right side, it favors anti-VEGF plus steroid. If it's on the left side, it favors anti-VEGF. But if it crosses the line, that means both are same. So if you look at visual outcomes, you see that there is no difference if you give anti-VEGF or anti-VEGF plus steroids. Even you look at the central subfield macular thickness, there is no difference. This is at 1 year. They also tried looking at the side effects, and definitely you see if you give combination, more of cataract, more of raised IOP. So today the evidence doesn't suggest that we should combine both. Again, many times we will also, when we combine and give, we really don't know which one worked to reduce the edema at that stage. Can we have this strategy? This is again one of the studies which I came through when it's a nice study done, a prospective study where they alternated one group with anti-VEGF, one started with corticosteroid, and then they changed in between. And you see here again, they found that visual outcome and OCT outcome both were better if you are giving only anti-VEGF alone. Alternate group, the outcomes as far as vision, outcome as far as macular thickness was not that great. So probably combining is not a great idea as far as diabetic macular edema is concerned, both in terms of vision, OCT and overall outcome of the patient. Thank you very much. Any questions? I'll be happy.
Yeah, very well summarized, Rajiv. I think we always push for combination, but now from what you're saying, evidence-wise, it says that there is no, benefit at all. But then how do you, I mean, I don't know about the evidence that they've seen, but clinically we have seen that sometimes, at least the chronic edemas,
It will work similar with when you switch only to steroids.
steroids.
See what happens when you have given both, you really don't know which
Which
works.
has worked, exactly.
So rather than giving one extra thing, you switch to steroid. That
So
will
what
work.
do you do in practice? How
I
do
switch to
you
steroid.
switch, and then when do you come back? If
So-
you're alternating, when
No,
do
I
you come?
don't alternate.
Okay.
So once I switch, I continue with that.
Okay. Until that stops responding.
Yes,
Okay.
absolutely true.
Rajiv, what do you do if there's center involving diabetic macular edema and there are areas of succinate rings in the macular
Definitely laser.
So we should
Nowadays,
highlight that
off-
also.
Yeah, off late.
Because we are speaking too much on anti-VEGFs.
Correct.
Like ophthalmology, retina has become anti-VEGF. So we have to talk about laser. Focal laser has a definite role
Definitely.
and is excellent results. So if you got a non-center involving diabetic macular edema and you can on a 90D or a indirect, if you're good in your indirect, you will actually see the thickening of the retina in the paracentral area. If you see that thickening or you see succinate rings, the succinate rings, the ideal place to laser is a light burn, Esperance grade 1 in the center of the succinate ring. You find excellent results, you will cut down the number of anti-VEGFs.
Absolutely true.
So anti-VEGF is not the kind of the answer for macular edema, because each anti-VEGF, actually VEGFs are very good for health. It causes the apoptotic damage to the photoreceptor and RP. So you should give each anti-VEGF based on each OCT which you do. The OCT has to be done on each follow-up of the patient.
Yeah.
Check the vision and correlate with the morphology. The morphology has to be seen. You have to see the outer ellipsoid band, everything, plus the inner segment for biomarkers.
Off late, I've been more doing that becomes my second before even steroid. Nowadays, what sir is telling, I've been more doing ICG guided laser. That really works in non-response.
But ICG has no role in diabetic
I will
retinopathy.
tell you, sir. So if you look at some of these, do a ICG, there will be some microorganism which you will pick up. These are fibrin filled, which don't.
That the
pick up on-
fluorescein will pick up.
No, that sometimes doesn't pick because the fibrin, it will not be seen on fluorescein angiogram. It
But
will
sir,
look as-
ICG only shows us the choroidal vasculature.
No, it picks up, sir. You have to just see, because this all I started last Arvo. There was an Israeli.
Can we
group
see
who
some
showed-
images?
You have some images?
Yeah, I have. I'm actually presenting it tomorrow, the meeting.
Okay.
So they were very bad edemas with thing that works pretty well with the ICG guided. So that's again coming back of laser in our treatment.
Okay. Thank you so much, Rajiv. Any questions for Rajiv, because he'll be leaving to another session? Okay. While Dr. Dogra connects his presentation, he'll be talking to us on DME worsening after cataract surgery. Any questions for Dr. Rajiv? He'll be leaving. Okay. Right. Thank you so much, Rajiv. Thanks.
Well, friends, at the outset, I thank Chaitra for giving me this opportunity to be part of this IC. I'm going to totally switch to something different, but maybe it is of great use to most people, because cataract surgery is something which is one of the commonest surgery performed, and we have challenges with diabetic macular edema. I do have financial disclosure as a speaker or a consultant to Bayer and Allergan. And as far as the cataract surgery and DME is concerned, I think we very well know that progression of diabetic retinopathy after cataract surgery occurs most of the time, and you'll find that, and it used to be very, very frequent early. And the proposed mechanism we all know is breakdown of the blood-retinal barrier and the post-operative inflammation. Basically, I think it is way back in ETDRS when they did cataract surgery on these patients. So it was very clear, if you have a mild NPDR, you can do routine cataract surgery, they'll do well. There'll be hardly any worsening. But in case there is a moderate or a severe NPDR, then almost 22% had worse than 5/200 vision. So that was way back in 1999 with ETDRS. And there are several studies which has shown association between ocular inflammation and progression of diabetic retinopathy. The surgical inexperience, I'll show you some of the examples, leads to progression of diabetic retinopathy after cataract extraction. The longer surgery is associated with increased postoperative inflammation and increased breakdown of the barrier. The problem is, I'll come to that also, we have to have a very good cataract surgeon who does a good job for these DME patients or diabetic patients. As well as we have to treat them not what you do today, only for a couple of weeks you give steroids and all those anti-inflammatory agents, longer is required. That's very important. And we also know that with the modern surgery, that is phaco, we are seeing this progression much less because maybe this surgery is faster, better than what we saw with intracapsular or extracapsular techniques. I'll just show you this patient here. She is a 41 young lady, comes to us 10 months late, and you can see what has happened here. You can see the telltale evidence of inflammation there. Maybe it was not treated properly. And you can see this, the other eye of this particular patient, hardly mild NPDR. And this is the other eye in 10 months. How bad it has become. It is a PDR already. And you can see very minimal changes. That is why it is mild in the other eye. And that's how the other eye has become in 10 months after cataract surgery. So that is the importance, what I talked to you already earlier. Now the recent evidence has come from this. This is an entire electronic medical record data from UK, which they published. They exactly came to the same conclusion what was in ETDRS way back, almost close to 20 years back. So the risk of treatment requiring DME increased sharply 3 to 6 months after cataract surgery for all grades of diabetic retinopathy. And patients with, again, SIMM, moderate and severe NPDR are particularly at high risk. So I think this kind of evidence can't be ignored. So what is happening now? There is a paradigm shift as far as the management of such cases is concerned. In past, cataract surgery was deferred until the treatment of DME was completed with laser. So at this time, simultaneous treatment of DME with intravitreal anti-Vegf or steroids has resulted in early cataract surgery with better outcome. I'm just showing you this particular patient here. You can see has received grid laser, 3 intravitreal, even triamcinolone. So while doing a cataract surgery on this patient, Ozurdex implant was given, and you can see at 3 months the results here. And in fact, this was a patient from the study, which in fact became a landmark and was published in 2013 in ophthalmology from our group, from PGI Chandigarh. And based on that, a lot of other studies were done, and Ozurdex is improved for cataract surgery in US and other countries now. And even the recent evidence you have in Retina 2021, same what says what was done that time. I'll show you also this patient here, 50 years old female, recently in Garewala Institute where I work now. You can see how bad the edema is. And here, 1 week before, Ozurdex implant was given. So there are 2 ways. One is some surgeon, like if we have a colleague of mine, Professor Jayadev, he always give when he does cataract surgery that day, but that very few people will do. But 1 week before, many can do. And then you perform cataract surgery, so you have a result like this, what you are seeing. So also there is evidence. I think even earlier speakers have talked about the meta-analysis. this meta-analysis, which is published in 2021, in DME patient, cataracts surgery combined with dexamethasone seemed to provide better anatomical outcome compared with cataract surgery combined with anti-VEGF. That is why, because this may be a question in many of you. So if your patient can afford and you don't have all those things, I think you prefer this and they'll have a better outcome. And it lasts 3 months. And those 3 months are crucial. That's why it is so important. So because anti-VEGF cover only 1 month. And we have these situations. Sometimes in a diabetic, you have posterior polar cataract, uveitic cataract, sometimes very, very hard or pseudo exfoliation. So much more bigger challenge. If you have some of these things, maybe you send the case to a person whom you don't like that much. I think your practice will be better, because that is what I'm showing here. So this patient, you can see not that much of retinopathy in right eye. This left was also similar. But after a complicated cataract surgery, what has happened? This was a posterior polar cataract. This ultimately went into neovascular glaucoma. And you can see not only everything was lost. So that is what need to be emphasized. And so what could be the recommendation? Achieve good metabolic control. That is for all patients. It's very important. Use topical steroids and NSAIDs for longer time after the phacosurgery is done. Don't use them like you do for other routine cases. No, because this inflammation, if it is less, then less progression. Perform excellent phacosurgery. Must have a phacosurgeon who does very good job. Avoid multifocal IOL. Don't put it. If it is even a severe NPDR or a moderate, don't put in them, even if macular edema is not there. I think these patients, once they develop macular edema, they become worse, and then they have a problem. And this has happened to some of the VVIP patients, where in DME, they put a multifocal IOL. Pre-op, per-op intravitreal, Avastin, Lucentis, I have mentioned everything here, but highlighted Ozurdex if your patient can afford. So are required to improve the final outcome. So in conclusion, always talk to patient, have a good counseling, inform the patient, likely decrease in visual acuity after cataract. A cataract is always associated with absolutely good vision. No, tell them, perhaps you're going to be worse than this. Then they expect much less. And it is very, very important for you that you treat this before, preferably, if patient can, then 1 week before. If you give Ozurdex and do surgery, they'll do much better. Of course, if you have more of a vascular component, you can even give them anti-VEGF, because sometimes they can bleed also. That also we have seen. You may have a component where you already have a proliferative changes there. And you need an experienced cataract surgeon. Again, post-op treatment need to be more aggressive and prolonged. So these are some of the things I thought will be of use to most of us here, those who practice and find it difficult to treat such patients. Thank you very much.
Thank you so much, sir. I think extremely important take-home points while Dr. Lalit Verma connects his laptop. Quick question, sir. There's a lot of controversy as to why one should not use multifocal or premium IOLs in patients with DME. Does the lens itself alter the course of the disease, or does it hinder the treatment process, sir?
It hinders the vision. Any maculopathy, you put a multifocal lens, and then your patient is after you. He'll chase you. So this is my take on that. Any maculopathy, please. At least I have faced this upteenth number of times from so many patients, and then they want something to be done for that. So any maculopathy, I'm not even talking of. So that is my take on this.
He said without maculopathy also.
One more thing is diabetic patients already have decreased contrast sensitivity. So with multifocals, their contrast goes down even further. So it's important not to put a multifocal but put a monofocal, because their contrast is already hampered by DR.
The problem is, you see, you have those rings. Even if they have some vision little bit in the paramacular other areas, even that vision is not there. So that's why they have so much a problem. That's how I believe very firmly. And so I keep on propagating
What about toric IOLs? People keep putting toric also.
I think toric may be because more for astigmatism and other things that different. But I think they come back to now trifocal. So they ask, we have now trifocal. They are also similar. They are also type of multifocal to me.
Because the dilemma with the VR surgeon is that, you say, हाँ ठीक हो गया, everything's okay. But you can't, obviously you should not criticize, but
No.
in this webinar and all, you should tell, but you should not.
Yeah, that is why
actually do it. It's not in the interest of patient, actually.
Yes.
Thank you so much, sir. Over to Dr. Lalit Verma. Really grateful that you could make it to the IC, sir. And he'll be talking to us on can surgery be the solution for unending injections for DME?
Thanks, Chaitra, for having me here. And DME today is synonymous with injections. Whether retina surgeon, anterior segment, comprehensive, anybody who sees DME, preferably OCT is done, and time domain OCT, they'll keep injecting, and patient is scared also. And he comes to retina surgeon in the last time, Dr. Sahab, bahut injection ho gaya, what to do now? And then Mangat was hinting at Ozudrex. Mangat, Ozudrex is your first choice or in first choice? So people, people come with this kind of picture, and obviously they tell Dr. Sahab, 12 injection ho gaya. And today, interval injections, honestly speaking, I will not hesitate to say, have become one of the main source of revenue generation. Faster revenue than cataract surgery also. And people keep giving irrespective of the picture. Diabetic hai, thoda sa swelling hai on the macula, keep giving injections. Sometimes without any rationale also. And this is one of the chart which my patient came, Dr. Sahab, itne sare lag chuke hain. And this is one eye, right eye, left eye. So patient gets exhausted actually, exhausted. You see, if somebody else is paying, it may not matter. Then patient will say, okay, Dr. Sahab, laga do. But if he is going from his own pocket, because in India, insurance penetration is not very high. So that is the reason, you see, it pinches him a lot if so many injections. It's a endless kind of disease. And this I copied from Google, that the sale of these injections are so high nowadays. And every company, biosimilar, they will keep coming to you, promote this thing. And we have to be very, scientific in our approach and show genuine concern for the patient. You see, if I am a diabetic or my father is diabetic, what will be my approach to, this? And consider economic factors, his paying capacity, and use very judiciously so that we can maximally benefit him. DME is not a single entity that all of them will have one approach told by Chaitra, Jayadev, by yehi sabko karna. That's not possible because there is a myriad of presentations. So many presentations may occur. Like Mangat was saying, one patient refer it to your enemy or whatever. So there's so many presentations. And it's a multifactorial disease. It's not only glycemia which plays a role. Hypertension has been shown. In fact, the work done by Mangat when he was in PGI was world-class work and quoted very often internationally and published in very high journals. Role of lipid profile, hypertension, even anemia. It was highlighted by their paper. Then glitazones, especially pioglitazone implicated, sleep apnea, cataract surgery is already highlighted. So it's a multifactorial disease. What I do is I'll scare this patient of diabetes. I'll call all their family members, but because it's not an individual disease, a whole family has to adapt to, if a person lowers HbA1c by 1, it helps quite a bit. So you scare him because diabetes is not going to go away. If he reduces the weight by, say 5 kg or lower, it helps all of us in proper management. So today, diagnosis is not difficult at all. FAOCT, a lot of people do. Octa, you have heard in the morning. Primary role of doing, the decision has to be made in combination. Because 3 things are very important. Vision, FA picture and OCT. And it's the combined, information from this you have to see. Like if vision is 6/6, I will hesitate unless and until patient has, neoaspiration elsewhere or a non-central involving diabetic macular edema where we can laser. But by and large, you do pay importance to how much is the vision. In fact, the recent study by DCR net that showed that in patients who have good vision, 6/6 or 6/9, heavens are not going to fall if you wait for some time, in instituting treatment for DME. The role of angiography is specifically if you have to laser, because Octa may provide information, but I would still today depend on FA. If I have to do laser in a patient, especially focal laser, I would like to pick up those leaks. Although flow studies in Octa may tell some information, but I still want an FA. FA is not dead even in the era of Octa. And role of OCT to my mind, apart from picking up various 5-6 categories of edema, is to rule out traction. You see, if you see picture on the top, this patient, you keep giving injection, nothing may happen. The top picture, there is an active pull on the macula. Then various categories of edema have been advised: cystoid, cystic. Some people may prefer steroids in a cystoid. So based on all this, whatever you have done, I would like to classify DME into traction and non-traction or combined. Tractional further classified into with vision loss or without vision loss, and non-tractional further divided into center involving and non-center involving, because that has a bearing. So this patient, who was already lasered also, had this edema. So one shot of anti-Vegf did decrease, although edema didn't go away completely, but it did help. So this patient was fed up of so many anti-Vegf injections, so we gave one shot Ozurdex. So he was a happy man, a banker by profession. So this lady had again multiple injections. So we gave Ozurdex multiple injections. This picture, last picture, is after nearly 12 months of third shot of Ozurdex, and even though there was some vitreomacular traction, but edema did go away. Vision improved modestly only. Her best corrected vision was 4/60 at the last follow-up. So what do you do if you have traction edema without vision loss? So without vision loss, answer is observation. Do not attempt to remove tractions, all the tractions which are there. So ultimately, function of the eye is vision only. So don't do heroic attempts to remove this traction, which is predominantly nasal here. So this patient is best kept under follow-up only, because vision is pretty good. What about patients who have traction edema but with vision loss? So here, generally surgery is the answer, but some people, I will show you one example. This was my patient who had injection, diagnosis as traction macular edema. So as we were preparing, I gave injection, but fortunately this hyaloid got separated. So this is not a very common occurrence, but it can occur. So you can attempt, I'm not saying this is treatment of choice, but sometimes you can. So this patient resolved, edema resolved, everything went away, surgery deferred. So surgery, what kind of surgery you do? I think it's a standard MIVS surgery, 25 gauge surgery. You put tricot to peel off the hyaloid in a patient who has traction edema, and try to gently increase the suction, engage the hyaloid face, and this hyaloid does come out most of the times in a single. And after you have removed the hyaloid, this patient had cataract also. A lot of times we combine cataract surgery. Very important, if you have a good cataract surgeon, like Mangat was saying, you have to have a very good cataract surgeon at hand also. And after this nice cataract was done, pupil was still good. So we went ahead and put trypan blue here to identify the epiretinal membrane. So I normally put trypan blue under air, and 1 or 2 drops normally suffice. So then I take this 25 gauge MVR blade to identify the edge of the epiretinal membrane. Here you see the edge, and once edge is there, you are very confident that you will take a forceps and then remove, as is being shown here. Take a forceps and this epiretinal membrane will come out. Next dilemma is whether after removal of ILM should be done or not. By and large, most of us do attempt to remove this ILM. And here I am showing this direct pinch and peel technique where ILM is being removed. And I am making multiple flaps initially of ILM, and try to remove from the entire posterior arcade. Once you are inside, try to do the removal of ILM in a complete way. So here we have this is a Bbg assisted ILM removal. And in this patient, there is not much surgery done, so we ultimately did only air fluid exchange and gas injection and did not do any oil. So this was one of the patient who was unhappy, and her OCT was like this. So we did this assisted with tetany MIVS, and she was a happy patient. 360 to 6/18 she recovered. This was another combined detachment, but you see the OCT picture pre-operatively and post-operatively. This is again foveal contour restored. So DME patients, you need not keep giving injection. Sometimes surgery, specifically with active traction, does help. So non-tractional, this was tractional. Non-tractional, now coming to non-tractional DME, center involving DME. highlight, I agree, anti-VEGFs are the drugs of choice. You have choice between various molecules. We will not discuss which one to use. Biosimilars are also entering in a big way. Then Ozurdex and lasers also are there. And after, even in non-tractional DME, suppose you have exhausted all the things. You have paid attention to metabolic parameters, injections, Ozurdex, everything has been done. Sometimes you still consider vitrectomy in a non-tractional central volume DME. Because there have been a lot of reports now. This data again, taken from the net. Definitely in tractional it does help. But even in patients who have DME without traction, so although anatomical success is more than the functional, but it does sometimes put an end to the injections. So my topic was how to put an end to injections. So this may help. So just to conclude, DME today is not blind injections and injections. Consider various factors. Consider the metabolic profile. Consider all the things before you pressurize patient by injection like valve. A lot of people call patient by eye up time penny eye. So this is the last slide. Tractional definitely PPV. In non-tractional, after having fed up and exhausted all the things, you can consider vitrectomy. Thank you very much.
So I have two quick questions. One was when you're doing the ILM peeling in the setting of a DME with a probably central large foveal cyst, would you do ILM peeling in any other way?
No, what we do is we do not actually, we do a foveal sparing kind of ILM. And because it's not like I showed the traction, if you pull ILM, you may de-roof the cyst and create a iatrogenic hole. So it's just leave it at the edge only.
And then you trim it with the cutter.
Yeah, trim it with the cutter. Use 50 as suction and highest possible cut rate and trim it.
Never across the
Never
fovea.
across.
So that's one important point. And second thing is, sir, have you actually gone ahead and done any vitrectomies for resistant DMEs?
And resistant, only 2 patients.
Okay.
Only 2 patients.
Any other experience from the
Because that is not,
audience,
you see, I haven't, because this becomes the choice if you keep getting good results. Because the results in non-tractional central volume DME patients who are fed up, so let the patient beg for it, then you do it. Because if you propagate and don't get good result, then patient will be an unhappy patient.
At least I have had a problem, although I have stopped doing ILM peeling in diabetic macular edema, because I had 3 patients where the fovea became so thin and their vision went down. Maybe it was more related to ILM peeling, and these are the cases where they were non-tractional. So at least I don't do it for quite some time now.
I agree with you, Mangad. Most of the patients, you see, ILM in macular surgery is totally different ball game. ILM peel in non-macular is different. And most of the times in diabetic, the kind of video I showed, this was one video which ILM came very easily. A lot of times you have to struggle, or it may come piecemeal, small bits of ILM. It may not come as it comes in macular hole. So I do try, but I do not insist. I will not, keep doing. If in one go or, I take out the edge, so I'll just loosen that. That's all. I agree with what Manga said.
Yes.
Yes, sir.
Yes, please, Dr. Apte.
Great talk. So I think that's the most challenging patient, the one that there's no clear evidence of traction. So I think that's a really, like you said, a patient discussion, because as long as you're counseled well about the vision may not improve, maybe reduction in number of injections.
Yeah.
Because if you went back to what we published with Protocol D, which was not the best study, but we couldn't tell the difference, whether they had an ERM or not. So I agree. I think unless you have a really good discussion, you could have these situations with severe foveal thinning and
I've even seen somebody doing surgeries for removing the plaque, the hard exudate plaque at the fovea. I don't know if anybody has really tried that. And
I read about it in Japanese. A lot of these Japanese used to do that and tease that plaque. I don't have guts to do that, and because you see any manipulation on the fovea or around the fovea does not give good results.
Yes.
At all. You compromise on the post-op vision. I'm 100% sure about this.
Yes. While I request Professor Atul Kumar to connect his laptop for the presentation, sir, is this your first instruction course as president of AIOS?
Second,
damn. I was hoping it'll be the first. Anyway, sir, thank you so much, and congratulations from all of us to taking over as the president of AIOS.
Thanks a lot.
Really privileged that you are part of
all
our
your good wishes and feedbacks and what all needs to be done.
Absolutely, sir. We are all with you. Thank you so much, sir.
Thank you.
Next, we have Professor Atul Kumar. He'll be talking to us on tackling recurrent or persistent DME even after a successful vitrectomy. Thank you, sir.
You've all been hearing very good lectures on diabetic macular edema, and I think just in the series of that diabetic edema can be very resistant or non-resolving, or you say chronic or relentless or recalcitrant. There's so many words they use, recalcitrant DME. So even after surgery, sometimes the conditions don't improve, the patient's morphology as well as the vision does not improve. So classically speaking, for persistent DME, what do we do? It's best to switch after 3 to 5 injections to another injection if you feel so. And of course, besides all this is the control of metabolic control and also laser. Because with the wide field, even with the Heidelberg, you can get about 102 degree field. With the patient moving right, left, up and down, so you can get over 100 degrees, which is wide field, and therefore peripheral retinal ischemia can play a role in diabetic macular edema. So we don't treat the peripheral retinal ischemia in the periphery. Anterior to the equator, you will end up with DME, which is thought to be due to Vegf release, but it's not the Vegf release from the center. It's basically, it's correct, it's better to release from the periphery. So all those lipid control, the hypertension control, as ACCORD study says, is very important. So the second is combination therapy. We already heard Rajiv Raman on that, and protocol U showed us very clearly that there was no role of combination therapy, and RBZ with ranibizumab with sham did as good as ranibizumab with Ozurdex. So no significant improvement in vision, but there was improvement in the morphology in the central macular thickness. You can do rescue laser, and laser always plays a big role in DME, though it's not supposed to be done in the center, but it can be done in the paracentral area where you can do focal laser. Or in the periphery, we can do a peripheral targeted laser based on the fluorescein. The fluorescein tells you where the capillary non-perfusion areas are. You can do rescue laser. So this is a very old study from the diabetic retinopathic network, and this drca.net has published a number of studies, one of which was led by Julia Haller, and they showed that for tractional DME there was significant reduction in the retinal thickening, and the visual acuity improved by 10 letters in 38% eyes. But also there was a decrease of vision of 10 letters, which is ETDRS vision. The ETDR is always in letters as compared to Snellen's vision, which is in lines. So it's more a 22% reduction in the vision in letters. So there was not a very significant improvement on when it comes to vision. So what is the role of PPV in recalcitrant DME first, before talking about recalcitrant DME after vitrectomy? It relieves the traction, and it shouldn't be done, probably I think it should not be done in non-tractional DME until and otherwise you've given up everything, which actually rarely happens. So only if you got tractional DME, and tractional DME does happen. There's some kind of abnormal hyaloid I've seen. This vitreous gets adhered to the fovea. You get a lot of VMT and ERM formation. Probably the laser also and all the inflammation setup leads to epiretinal membrane formation. When you see these ERMs, you first try the anti-Vegf. If the anti-Vegf doesn't get relieved, then of course you should counsel the patient that you need to get a epiretinal membrane peeling, because you show him the serial OCTs. Serial OCTs, you show him that the DME is not going down the way it should, and it's probably the ERM which is causing the vertical traction, and this leads to the cyst becoming very vertical. So that's an indication that you may need to do, and also look at the morphology, the ellipsoid band, and also the kind of neuroretinal degeneration setting in, the drill setting in, all that setting in. Maybe you can discuss with the patient. It's always important to talk to the patient, because his vision may not still improve, and he may be on you after the surgery that what have I achieved. So everybody wants vision and the patient angle. They don't understand what all is drill and all that stuff. So it's important. But of course, by removing the ERM and also if suppose you're removing the scaffold, then you increase the delivery of oxygen to the retina. This has been shown in previous studies, and also the inflammatory mediators of DME like Vegf. But Vegf is not the only mediator. There are a lot of other anti-angiogenic mediators. There's a limited role of vitrectomy in cases where there's discontinuity of the ellipsoid. So please look at the outer bands. If there's a ELM ellipsoid band discontinuity, I would rather say that we shouldn't go in for surgery and keep the treatment conservative. and inform the patient about the final visual outcome, and probably he won't attain very good vision. Give him best correction visual glasses, give him some low vision aids. All that plays a role. And submacular exudates is a harbinger of poor guarded prognosis, and usually no surgery, of course. And you may try steroids, because steroids work somehow in submacular exudates. You can try triamcinolone, or usually patients can afford Ozurdex if they can. If they can afford the 700 microgram pellet for 3 months, it may help to some extent, but not totally. He's not going to get 6/6 vision or something, but he'll probably end up with some improvement in his vision, will carry out his daily activities and all that. That's what they need. So you've got to discuss it with the relatives and the patient. Also look for other changes. This is a patient who had a DME. Sometimes post-vitrectomy, there's a little inflammation and the membranes form. So in the first surgery, if you've not done the DME, the taking care of the macula carefully, then these membranes form. A thin, thickened, translucent membrane is formed. So peel it across. The mild bleeding, you don't worry about bleeders so much. They generally stop. They don't. You just identify the bleeder and make sure that you don't take the pressure to 60 for too long. And here you can see that the OCT shows, as just talking, there's a IOCT. I use the IOCT with it. So the IOCT shows me that there's a very thin fovea. So I'm not going to peel across the fovea. So what I do is I peel the ILM across the center from the paracentral area and leave the ILM in the center, like as if I'm doing it for a hole. So I've left the ILM in the center bunched up, because I'm not going to peel the ILM in the center. You see the foveas, because of cystic macula, it's a very thin fovea, atrophic fovea. I'll create a hole, definitely. If not now, it will be post-surgery. So it's best to bring the ILM in the center and leave it there, and then check the IOCT, because the intraoperative OCT gives you a lot of information about the status, and you be sure about that you've not created a iatrogenic break, and leave gas at the end of the surgery, and probably SF6 will be insufficient. That's what I usually do. And add on some laser in the periphery. Sometimes, so this is a patient, is a post-vitrectomy recalcitrant DME. So many of these cysts actually are ORTs, and they are photoreceptor degeneration, and this is a sign of neuroretinal degeneration. Neuroretinal degeneration is never cured by anti-VEGFs. So there's some degree of drill. This is the fovea. So there's loss of inner segments, and also a serous detachment. And there's of course, the ellipsoid band is somewhat continuous, but there's a lot of fibrin there, and all that stuff. And the retina is extremely thickened. These patients don't have a very good prognosis. You can keep on injecting, but somebody recalcitrant DME. This is another patient who had his vitrectomy, and he came back. So the macula was not tackled by somebody, and so we had a little bit of traction still there, and probably a very thin fovea. So these kind of patients, you'll probably go back in and do the surgery and make sure you remove this fibrous ERM, and because there's no other option without surgery. And if you do any anti-VEGF, it might even worsen him. So you go back and do it very carefully. Probably spare the center if you can, or just trim the edges as was talked, and don't tackle this area, and remove the traction from the surrounding areas, not from the center, peripapillary area. So this is a diabetic patient. So, but he had a VMT. So I just did it recently. I just want to show you how we tackle VMTs, and this is done on the Ingenuity. I use the 3D visualization system, and the 3D visualization, of course, no DR, but this patient had diabetic retinopathy, he had a VMT, and so show you the VMT. This is the wave of the hyaloid, which is lifted up as you do, and that's the first surgery. And this puts some brilliant blue G dye, and I like to stabilize these retinas with VMT and all, with little bit of perfluorocarbon bubble, small bubble, and put some additional Bbg under it to stain it. So you can see the traction will be visible to you soon. Yeah, it just comes and goes, because see the retina is lifted up from the region where there's a traction. So the IOCT guided you make sure that the security which you have is that you're sure that you're not created a break. So the IOCT really provides you that on the table itself you see the retina settling back. If the retina settles back, you're satisfied that you've not created a break, you've got the retina settled back. You aspirate the PFCL, which is never left behind, replace it with air gas. So the issues that there's chance of ERM formation, comorbidities, inflammatory mediators, in vitrectomized eyes, the pharmacokinetics changes. So the issues are that there's an increased clearance of drugs. So anti-VEGFs will, though the dose is the same, but there's increased clearance. The dose does not vary. Only in silicon-filled eyes, half the dose is injected. But in gas-filled eyes, same dose of the anti-VEGF injected. If you're injecting 0.23 ml of Lucentis or Accentrix, same will be injected. But in case you're injecting a silicon-filled diabetic eye with DME or for giving an anti-VEGF, you have to, finishing. So this is the last slide, and there's a role of intravitreal steroids in vitrectomized eyes because of the increased clearance of anti-VEGF. So the rationale of using anti-VEGF. Now there's also a lot of work on fluocinolone implant, and FDA has given it approval. And just recently I was reading 10 days back, the Paladin study which has come. It's a 3-year safety and efficacy profile of 0.19 ml fluocinolone implant for DME. It's by Singer et al. And Ophthalmology 22. You can refer to this, and you can see that the fluocinolone did improve the final efficacy and was safe. They said very positive results. So many of these studies are industry driven. So you have to kind of weigh it with the options you have, because there's a secondary glaucoma, you might need trabeculectomy, you might need some valve surgery, so all that. So please don't go blindly into these studies, but this is a very recent study. Thank you very much.
Dr. Atul Kumar, I think he's shown us how not only to manage tractional DME with surgery, but also how to handle post-operative. We have one keynote address by Dr. Apte. Request you to please come over. This is part of the AIOS initiative. With regards to the keynote, he'll be talking to us on submacular hemorrhage. Dr. Rajendra Apte is Paul A. Distinguished Professor. He's the Vice Chair for Innovation and Translation. He's the Director of the Jeffrey Ford Innovation Fund and Vitreoretinal Fellowship. He's also a Global Professor, and there's lots more. He's from the Department of Ophthalmology, the Developmental Biology and Medicine. Over to you, and you'll be talking to us on submacular hemorrhage.
That's right. It's a little bit off topic, but we do sometimes get submacular hemorrhage in diabetes. So these are my disclosures. The only relevant, I'm really not going to speak about anti-VEGF, but would be the ones with Roche. So the thing to remember with submacular hemorrhage is a lot of our discussions in the past have been with wet AMD, but it can happen, submacular hemorrhage can happen a lot with many other conditions. And so what I thought I would do is the summary of my talk will be that we really don't know what to do with these patients. And so it's really an individual customized patient approach, and I'll present a small study we have and would love to have people contribute cases to it on non-AMD related hemorrhages. I'll show you a video of a choroidal rupture case. So why do we worry about subretinal hemorrhage? Submacular hemorrhage is good data from as early as the 1980s that subfoveal hemorrhage is toxic. And so if you have rabbit studies where you put blood under the retina, you can get toxicity actually as early as 2 days, but by 2 weeks, you can get pretty profound effects on the outer retina. And so traditionally, the history of submacular hemorrhage management has been all of the above. We started with doing nothing, and then people tried clot removals, pneumatic displacements, and then with anti-VEGF, we all know that we always would like to give it a try. There was this interesting case from 1983 that I discovered where it was reported in this 28-year-old, we obviously didn't have good options then, with blunt trauma injury, where they actually did diathermy through the retina choroid and the sclera. And the idea was to drain the blood out of the eye. And this patient remarkably had a vision improve from 3/200 to 20/25. I don't think any of us are brave today as in 1982. So the earliest anecdotal evidence for surgery was these reports of clot extractions and individual patients where people did macular surgery and all kinds of things, removing the CNV, washing the blood, and this had, again, anecdotally decent outcomes, but usually better outcomes are reported, poor outcomes are not. So that's why these individual cases are nice to see. But based on this, you had the submacular surgery trials were designed. And when you did this submacular surgery, and there were multiple groups I won't go into, what the trial showed was that submacular surgery, as it was done then with removal of the choroidal neovascular membranes was not beneficial. That was ultimately the conclusion. And then there were complications of surgery, of course, with cataract progression, rhegmatogenous retinal detachments. But the one nugget was that it did reduce at that time the risk of severe vision loss as defined by 6 lines of vision or more. But again, remember, this was before the anti-VEGF era that we've been hearing a lot about now for diabetes, but also for AMD. Pneumatic displacement was first reported in 1996, just doing a air or a gas bubble. Today, it might be combined with an anti-VEGF agent. There were discussions about doing intravitreal TPA. Again, very inconsistent results as a risk of retinal tears or giant retinal tears. There was recently a DRCR protocol for VMT that was terminated because of a significantly higher risk of peripheral retinal tears with pneumatic displacement for vitreomacular traction. And then everything changed, of course. We had SST results for submacular hemorrhage, but then you had Avastin used off-label, and then multiple anti-VEGF agents, as you heard, that were since developed after 2004. And so there are a lot of considerations now, and this is really for AMD, but then it gets even more complicated in non-AMD indications. And I've just listed some of the things that we discuss with the patient when you have someone with a submacular hemorrhage. In general, if you have small hemorrhages or it's of chronic duration and you're concerned that you won't be able to move it, poor visual potential or systemic risks, I think all of us would at least treat them with anti-VEGF monotherapy if this is AMD or even non-AMD indications. And with vitrectomy, again, this is very customized because our evidence is somewhat soft. Larger hemorrhages, recent hemorrhages, patient very motivated for surgery. Why do we talk about surgery? Because we know that from natural history studies, 40 to 50% can develop fibrosis. If you decide to intervene, you should intervene early. There's a lot of discussions we don't have time for, whether you should put subretinal air, subretinal Avastin, intra or subretinal TPA, but again, if you ask the panel, everyone probably does it a little bit differently, and we don't have clinical trial data to support one or the other. But I'll give you an example of a case and just quickly summarize our short case series we did with Raja Narayanan from LV Prasad. So this was, again, a patient who had a traumatic injury to the eye, had an exploration for a ruptured globe, but there was no evidence of it. And this is how he presented to retina with, I would call this a small but thick submacular hemorrhage. You can actually see where the choroid is there's a choroidal rupture on that bottom OCT. And so we had a long discussion with this patient because the vision is actually quite good, 2300, but he was very motivated to do surgery and did not want to wait and see what happened with his hemorrhage. What's interesting, I'll show you in the video here, you can see he has an iridodialysis, which we did not repair in the first surgery. And this is a case I did with my fellow Kishan Patel, who will now be at UT Southwestern. So hopefully I can get him to come to this meeting next year. But there's nothing unusual about this surgery. This was a vitrectomy. Few consideration, traumatic patients, you have to examine the periphery carefully, as you'll see here. The hyaloid is almost always attached. And so you cannot sort of displace blood and do subretinal injections unless you'll see here. And it was shown in a couple of videos in the previous talks. I use usually triamcinolone to elevate the hyaloid and then examine the periphery. And you can see this person actually had a retinal break that had not been seen previously during the clinical exams outside. So you obviously want to laser the breaks. This is a 41 gauge. I like the flexible cannula because it tends to not break and it's easy to maneuver. This is subretinal. This is basically TPA. And you want to use the vitrectomy machine with it. You can see here, this is why I say these cases are sort of questionable, how do you do them? Because the hemorrhage is already clearing in this patient. Although we checked his vision that morning, it hadn't improved, did not have an APD. The goal here is to create a bleb. In this patient, there was no evidence of choroidal neovascularization yet because the injury is fairly early. There's no reason here to inject subretinal air or create very large bubbles because you saw that the hemorrhage was relatively small in size, although thick. And then the idea here to just make a retinotomy with the translocation needle
make the bleb and then do a gas exchange, which for the sake of time, I'll just skip this part. And you can see here, this is again, we did do intravitreal Avastin for no good reason. I mean, I think in a choroidal rupture case, you could have just waited and done injections if they did develop CNVM. You can see a pretty large rupture here in the fundus photograph. But the on the OCT, you can appreciate that the anatomically the macula looks quite good, and the patient actually improved to 20/25 vision. I don't claim that the surgery did this. Again, I could have just watched the patient, and probably if the hemorrhage had cleared, they would have had improvement in visual acuity. So we did a small series of just retrospectively analyzing these types of cases, and we're still putting this together. So if anyone has these kinds of cases, please contribute. With Raja and Kishan, and hopefully we'll be putting this together soon. But here's just a sample of the 13 cases we put together. You can see there's a patient with diabetes, Irvan, few micro-macro aneurysms, a RAP case, and then mostly traumatic subretinal hemorrhages. And really, this is just the range that you're seeing of the duration. So you can see some of the cases were actually quite long in durations, fairly thick subretinal submacular hemorrhages, on average about 700 microns. The one thing to remember is that the hemorrhage has to be subretinal, because if you have just purely sub-RPE hemorrhage, there would be no benefit of doing this surgery. Although there are a couple of reports of trying to displace sub-RPE hemorrhage, I've never done it. Usually gas tamponade, one patient here had oil placed in the eye, and then 15% had bevacizumab at the time of surgery. Overall, there was a significant improvement in the visual acuity. You can see this patient started with fairly poor acuity at onset. And on sub-analysis, there was not any difference in terms of what the final visual acuity determinants were, such as presenting vision, thickness, duration of symptoms, or age. And so to conclude, again, in select patients, I think this is a good option. Again, patient education, and as long as they understand kind of what the goals with this surgery are. But it's a challenging complication, especially if the hemorrhage doesn't clear, because you have a lot of cases that have been reported where you have loss of ellipsoid zone, submacular fibrosis, and that's what we all worry about. But I think without good clinical trials, again, it's hard to establish consensus. So I do feel there's a benefit of this surgery in select patients where the physician and the patient are both on board and understand what the goals are. Thank you.
Thank you so much. Very interesting and fantastic. I think we all would have some similar cases and be great to contribute. We'll get in touch with you for sure.
That'll be fantastic. Thank you.
Thank you so much. Thanks everybody for your attention, and thanks to my fantastic faculty, which every year we repeat the IC, but it's still something new to add. Thank you everybody.